Jessica Ernst, and I am the Regional Administrator with St. Croix Hospice. What that position means is that I work pretty closely with different hospitals, care centers, assisted livings, doctors, and we try to bridge the gap in between when you guys have someone who needs care and my clinical team. So that's kind of what my position does. We'll talk about all the positions that we have a little bit later in the meeting, but I'll let Anna Maria introduce herself as well and tell you guys a little bit about her position.
Yep, my name's Anna Maria, and I'm a full-time RN case manager with St. Croix Hospice. I live here local in Carpenter, and so I've been with the team, like we had talked about a little bit ago, for about 4 years now. So it'll be 5 in November. So
What I'd like to do is just kind of go around the room. I want to, if you guys could tell me your name and then one unique fact, and I'll start with the one unique fact. I have 5 teenagers, and I've survived this far between the ages of 15 and 18, 4 boys and a girl. So.
well, one unique fact about me is I help my mother-in-law with concession stands in the summertime, making funnel cakes and corn dogs. For fun.
I'm Lori. I don't know. I've been here
Croix.
35 years. And I collect Croix.
Nancy. I'm an RN here, and I've been here second longest next to Lori. I don't know. I don't find myself unique at all, so
I can't think of anything right now.
I'm Anna.
I don't know.
She's building a house.
And it's super stressful.
I've heard that.
It is.
I'm Kim, and on my downtime I like to quilt.
I'm Katie. I made birds today.
Fuzzy birds.
I'm Carissa. I'm CNA, and well, today is my birthday.
Happy birthday. We brought you chocolate just for your birthday.
Thank you. Much appreciated.
I'm Katie. I'm an RN, and I do not have anything unique that I can think about.
All right, so we'll go ahead and get started. Who here personally has ever had an experience with hospice? A loved one, a friend? All right, what about professionally? What have you guys seen with hospice? Anything that really just stood out?
Well, for me, this is my first time having hospice patients as a CNA, so that was interesting just to see, you know, how, I mean, you take care of them the exact same way as you do every other patient, you know, I guess that wasn't what my thoughts were when it came to hospice, but.
I see.
One of the things with hospice that I like is the family has accepted, you know, that they know that this is happening and that they've accepted what's to come.
I see.
Whereas their other patients, you know, it's kind of, this is it, but you know, there's not that much of a warning.
Gotcha. Anybody else? Okay. We like to obviously always know sooner rather than later when there's a hospice patient, and like you were saying, you know, it's so important when we can step in and the family knows, hey, this is it. That's what hospice is all about, but that doesn't mean that it has to be for those last few weeks of life or even the last few months of life. Patients can be on hospice for quite some time, and we're going to talk about that a little bit later. The first thing I'd like to do is maybe talk about some of the misconceptions of hospice. I'm going to just kind of read a few things to you guys. The first one is, I worry that my loved one will die more quickly if I sign up for hospice care. Have you guys ever heard anybody say that? I think that's something that, you know, as we move forward in the hospice world, that's something that, you know, we're having to overcome. We approach that by saying, hey, you know, the research shows that the holistic approach to hospice provides to patients the support, they get about 29 days longer, more out of life, and it's a little bit better of quality of life during those 29 days because we are so hands-on and working with the care team that's already in place, which would be you guys in this scenario. The next misconception of hospice is, let's see here, well, another misconception of hospice is, you know, I don't have any money, I can't afford to pay for that. So typically, you we overcome that because hospice doesn't cost anything. There's no cost for it. It's part of the Medicare benefit, and I can tell you that my entire hospice career, and I don't know about you, Anna Maria, I've never had a patient that's had to just outright pay for hospice. Sometimes if they're not quite old enough to meet the Medicare guidelines, they might have private insurances, and there might be a copay, but typically when they're terminally ill, they're going to find that they've probably already met their deductible. And if there's just some extreme case to where that can't be met, then we can definitely step in and talk with them about some charity care, and still take them on our caseload, because we would never deny anybody for their inability to pay.
And I've had that situation in my experience with a couple of Mennonite families around here, and caring for them is using that charity case for them and being able to provide comfort care at the end of life, so.
So we'll also talk about some of the benefits. 36% of the patients reported that the pain that affected sleep at first was, let me restart over. 36% of patients reported pain that affected sleep at their first hospice care visit. Obviously in the hospice industry, I think you can attest to this, Anna Maria, we are experts in pain. So for example, let's just say that we have patient XYZ that's maybe has some type of a fracture or a break, and you guys have done every single thing that you can, and there's nothing that can be done. This patient's elderly, let's say they have a severe COPD and maybe cancer too, and it's been determined that hospice is the route we're going to go. So we can come in, and typically I would say within about 1 to 2 visits we have that pain under control. So it's something the families see right away, and it's a team effort, and it's a team win, because then we can step in and help you guys as well, and be that sounding box for the family, and just get things to where they need to be. We definitely, can help with fewer hospitalizations. I'm sure that you guys working on the floor see the patients that are in here over and over and over again. I don't know if you guys see that often. I know in some of our other hospitals that seems to be a problem sometimes. Once we're involved, they typically call us. We're the new 911, and our number one goal is to keep them at home, so we're not having to bring them back to the hospital as much. Obviously there's fewer invasive treatments. When somebody elects hospice, that typically means that they've probably already tried everything that they're possibly going to be able to try, and there's nothing left for them to try. That's not saying that, we'll just say that Betty Sue comes on hospice and then she decides, you know what, I'm feeling good, and we see her starting to rally. She might say, you know what, there's this new treatment out there and I really want to try it. So she might come off of hospice, graduate from hospice and try that treatment. And she's always eligible to come back on as long as she meets criteria. We find that the families report a greater satisfaction in care, which is good. Oh, did you have a question?
Oh, no, sorry.
That's okay. You guys just stop me if you have questions. I tend to just kind of keep moving. I'm pretty passionate about this. So the families typically, definitely report a higher level of satisfaction, and it's not that they don't love what you guys are doing. It's just that, like we were saying earlier, when we reach that point to where they are at their wits' end because they've tried everything, but they want more, and they want this and they want that. We have a whole team that works with them, from psychosocial services, our chaplain, nurses, aides, so we're able to kind of reach them all around and pull them in, and we're so aggressive with what we do and how often we're there, and the communication with the families. They really, really like that a lot.
So how often do you go to somebody's house? I mean, are you there half hour and then you're gone, or does it vary?
If it varies, it depends on what their needs are first and what their care planned for. I've had patients that I've had to see 7 days a week, and I'm there maybe up to 2 hours if family needs it. It's not just about the patient and their symptoms, but how they're doing, especially our home patients where their loved one or spouse is the primary caregiver and they're getting burnt out, so you're spending time with them. You're spending time with the daughter, with the son that's helping provide those comfort meds. So it just depends on what their needs are and what their plan of care for. And the same with our aides. Our aides can go there up to 7 times a week as well.
Oh, really?
Yeah.
And it's really good because, a lot of the families, and I'm sure that, you guys probably know many of them in your community or maybe in your own family. I know I personally just went through it with my family. They're not caregivers. They don't know what this means, what we do every day. They don't understand what it means to bathe a loved one that is no longer able to walk on their own. Or they don't know what it means to change a bag, when someone's path. They don't understand that. So it's good for us to be able to go in and train them. When we meet them in this setting, when they're in the point of crisis and you guys are like, all right, we're discharging to home, and you called us and we come in and we're working with you guys, we start that training with those loved ones right then. And we start talking to them right then. We meet them where they are, and we like to start that before they ever even get home. So they have a good idea and they're already accepting what's to come. Especially when it's that non-caregiver loved one that's now gonna be the full-time caregiver for mom, dad, sister, aunt, brother, whoever. So hospice, we talked a little bit about the communication with the families, the patients, and then obviously, with the hospital being you guys. That's something that we really pride ourselves on in hospice. We definitely reach out, go over, above and beyond, because this is a one-time thing for us. There's never a chance to do this over. So we definitely, talk to the family numerous times about everything. We find out initially during the admission process what their communication method is, what they prefer. So we then use that and we talk with them. We talk with our care plan team as well, and we keep them in the loop. We have what we call IDG meetings, which is our whole team every 2 weeks, but that doesn't mean that we can't change the plan in between if needed. It's constantly a moving piece to what we do. All medication and DME changes are discussed. That means that, if we decide that something's no longer beneficial and it's more of a burden, or if we decide that they need a Broda chair, or if they need a hospital bed, whereas before they didn't, we discuss that with the family. We never just go and order anything. We want them to still be in control of their care. The consistency in the staff is vital for both the hospice as well as the patient, the family, and then the hospital staff. We also pride ourselves, as you can tell, on keeping teams together. It's so important, especially let's just use a dementia patient, for example, to have the same people, even though they might not recognize them from day to day. It's still important for us to have the same team coming in there that they know. It's also important for you guys to know that if you call and say, hey, I've got a patient that's, really failing and it's 3 o'clock in the morning, it's important for you guys to know that it's probably gonna be Anna Maria, Kaylee, or Stacy that's gonna be coming. Because we pride ourselves in that consistency in our staff. So we want you guys to know us and be comfortable with us, and it's hard to do that when there's constant change in the team. Feedback is important. You guys will routinely maybe hear us ask every single one of you when we see you when we're in here, how are we doing, or how did we do? How did you guys feel like that last admission went? Was the communication okay? It's not that we feel like we've done anything wrong. We just like to make sure that you guys constantly have communication with us. We want to know that if there's anything that you guys feel like we can improve on, that we can. If we're doing something well, we want to know so that we can continue to do that. Hospice needs to complement the family and facility by customizing the care and approach. So another misconception of hospice is they're going to come and move in my house and they're just going to be here all the time. That's not what we are. We are an extension of the family. If they are going to a facility, we are an extension of the facility, meaning that we are going to be the new 911. We're going to routinely come and see them every week, but we're not going to be there 24/7 unless we're in an absolute crisis situation. And that does not occur that often. If there's a situation where we cannot get someone's pain under control, and we have to do something immediately, that's when they would come here. We have a GIP, which is a general inpatient contract with Mitchell County. So they would come here and then they would be under your care and we would still be involved as well. And I'll let Anna Maria talk a little bit about how that looks when we reach a situation like that and maybe give an example.
Right, and we have not had one since I've been with the team where we'd have to use general inpatient. I did have a situation a couple of weeks ago where it was almost like a continuous care change in the plan of care where they were having increased restlessness. The lorazepam wasn't working, the liquid morphine wasn't working, and I had our primary doctor on the phone and I had our medical director on the phone, and we were doing Haldol injections to get the patient comfortable, and I stayed there until we could get her symptoms under control. That's called continuous care. Now, if we couldn't have gotten symptoms under control, we would have been calling a neighboring hospital that we have a contract with. This is what's going on with the patient, and giving y'all an update and a report so that we can transfer them over. So
who's your primary doctor that you contact?
If we've got Dr. April McQuillan, Dr. Luke Brinkman, Dr. Mary Parad, and we're getting ready to sign on another one, Dr. Rick Mulberly from
Oh,
New
okay.
Hampton.
Several, okay.
Yep, so we have several of them, and then we never replace their primary physician. So, you know, if they wanna keep Dr. Ross stays in charge of their care, plus then we have our medical director and then our team working with them, so.
Does that answer that? Okay, good. All right, so where is hospice provided? The patient's home, a family member's home, assisted living, nursing facility, a residential hospice, which we do not have a hospice house, but in some scenarios, some hospices do, or anywhere the patient calls home. That's where we're going to go to, and that's where we're going to set up treatments.
And it could be here in your
It could be
hospital,
here.
so.
The hospice network, so obviously it's gonna be the traditional family, the extended family, friends, neighbors, coworkers, the facility staff, and the community at large, meaning volunteers or anyone else, church groups that might be involved. And obviously there's a process for us when we're bringing someone on board with hospice that, you know, we go through who can we talk to and who you know, can't we talk to, and we go through HIPAA and stuff, so. The family-centered care, the patient and family, we view them as a unit of care. We talked a little bit earlier about the education of the dying process. We start that immediately. The minute that we are on the ground, we start that. We typically do things a little differently with St. Croix. We try to have Kayla, our social worker, at as many of our family meetings as we can, just because she's so good with going ahead and just starting that process immediately that only social workers can do, of identifying and asking the what ifs and the whys and answering the questions that they have from the psychosocial side of things. You know, the family, we definitely leave them in charge of the decision making. You know, we help with giving our opinions, but at the end of the day, it's still the care that the family wants. Now, I do want to clarify a couple things on that. There's occasionally going to be a family that's going to say, how soon can we just get this over with? My loved one's miserable. We cannot do that, and we will not do that. But the question is asked sometimes. We, you know, definitely want things to be in the natural process of life, and it has to run its course. So, privacy is of the utmost importance to us. It's one of our top priorities with compliance. We follow the same guidelines that you guys do, and we can't release information on anyone or anything unless we have permission. So, we really want to bring meaning and purpose to life. You guys will hear hospice nurses, hospice aides, and social workers say over and over that it's quality versus quantity at the end. That could not be more true. We want to know what it is they want to fulfill in their last days of life, and we want to help them do that. It's no longer about getting treatments that's going to prolong life for a year or two. It's now about fulfilling those last memories and giving the family closure and wrapping up any loose ends they might have. Bereavement, once again, our social worker, she is amazing. She's also our bereavement coordinator. She follows up for 13 months after someone passes away. She's talking to the family. It might not always be in-person visits. Sometimes it's phone calls, emails. Some families need a lot less than others. But she also does in-person bereavement counseling as well, if that's what's needed. And I know, you know, that if it was needed longer than 13 months, we definitely provide that as well. It doesn't have to end at the 13 months. So you guys heard me earlier talk about our IDG group. This is made up by our medical director and the attending physician, the RN case manager, the hospice aide or homemaker, our social worker, the spiritual care coordinator, and chaplain, which you guys will meet him at some point and you'll never forget him. His name is Brad, and we call him Bowtie Brad, because I think he has a bow tie in every color. A little bit about him, he is actually serves in the military. He is amazing, to put it mildly, loves what he does and has a huge zest for life, so you guys will have a lot of fun with him when you meet him. He is amazing working with our veterans especially. He really seems to have a knack with connecting with them. So even if you guys ever have a patient and you just need someone to come and visit, that, you know, veteran to veteran, call us, because he would love to do that. Love to stop by and just say hi, even if they're not a hospice patient. Volunteers, I say, are probably the most important piece of what we do. It seems like our volunteer, and we have a great base of volunteers, really seem to find some level to connect on with most of our patients. And I'm going to use someone that we had here in Osage, for example. This individual loved music, so we were able to pair her up with a volunteer that also had a passion and a love for music. And the joy that the volunteer has brought to this patient's life has just been amazing. And I think vice versa. They really look forward to the time they get to spend together and so forth. So the next one we're going to talk about is a therapist. PT, OT, music, massage, and even pet therapy. Have any of you ever seen music therapy in action? Okay, so recently I was at a nursing home in Decorah, and we had a big group setting, and our music therapist was playing. Well, we had our group of hospice patients that are on our service at one table, and we had provided little music instruments for them to pick up and play, like the little music shaker eggs and some tambourines, a little drum, things like that. And we had them kind of scattered throughout. There were people that I have seen that have not really been very responsive as far as verbally or even being able to ambulate very well or even move their hands a lot in quite some time. They literally were able to hold on to those instruments, and they were trying to speak the words and sing the words. They could not do that very clearly, but they could keep to the beat with the little musical instruments. It literally brought tears to my eyes. It was so beautiful. Very passionate about music therapy. Another story about music therapy, I was in Platteville, Wisconsin at a nursing home visiting, and there was a little lady that kept walking by. We were serving ice cream sundaes. Our music therapist was playing, and she kept walking by for like 20 minutes. Well, I seen her go down the hallway, and she comes back, and she has this little guy by the hand, and they walk right up through the crowd, and they're standing at the front, literally like right by the music therapist, and it was a guy. And he's like, just like, do I keep playing or do I stop and talk to them? Because they're literally like right here, and there's probably 40 or 50 people in the room. And he stopped playing, and he turned to them and said, what would you guys like to hear? And they said, You Are My Sunshine, or the wife did. He started playing You Are My Sunshine, and she started singing it. This man had pretty late stages dementia. He had no meaningful conversation with family. He didn't really recognize a lot of people, and I don't even know how long. But she was able to have one more moment with him. He was able to sing along. Literally, like they were dancing. And it was just the sweetest thing I've ever seen in my life. Like, I was crying, the girls that were with me were crying, because it was literally a storybook moment. But the thing that was the most precious was I didn't realize that a granddaughter and the daughter worked at the care center, and they were able to see this. And the way that touched those two individuals' lives and the stories they were able to go back and tell their family was beautiful. Because they had not had that moment of any meaning for a long time, And getting to see a piece of Grandpa again, it was pretty cool.
And I've seen it used for like anxiety for my patients that have Alzheimer's, that are real anxious, and families not quite ready for the medications we use in hospice, and getting those music sessions increased and that anxiety level come down throughout the process, or a COPDer that's having a lot of dyspnea and having that breathing come down and that relaxation. That's amazing to see too with music therapy.
And massage therapy, it's just equally as important. We do have a massage therapist on our team as well. She specializes in hospice and elderly patients. She does a fantastic job. Sometimes, we have that ache and pain that medicine just can't reach. But it seems like when she comes in, she can sometimes bring them quite a bit of relief from just massaging that area, or once again, helping bring that anxiety level down through touch. Last but not least, the counselors. We do have a dietitian on board as well, and we talked a little bit about the bereavement counselor earlier. And you guys are probably thinking, well, why do you have a dietitian if they have hospice? Well, the reason we have a dietitian is because, as their food needs change, we can bring her in and talk with the family about that. We can identify, what can they eat, what can't they eat, and see what's going on with that. All right, so this is going to be kind of a interactive part of our presentation. Who can tell me one diagnosis that would qualify someone for hospice at end stages of life?
Cancer.
Very good. All right, you get a piece of candy. Next,
Oh, she's got two
Page
pieces
open.
again.
Another one?
Yeah, ALS, we've had some patients.
Very good. COPD is another one. Liver disease, kidney disease, renal failure. We talked about dementia and Alzheimer's. That's kind of a difficult one for us. There's such fine criteria for that we really have to make sure that we have other qualifying factors a lot of times. But if you suspect that they might qualify, definitely look us up for that. Because chances are if they have something else going on, we can definitely come and take a look and find something else in the chart, you know, and get them on board. And then stroke. The thing with stroke victims, when they come in, we have a 3-day waiting period before we can do anything with them, because I'm sure you guys have seen how they can rally. That 3 days are really the determining factor as to, you know, how things are gonna go. So, I'll let Anna Maria talk a little bit about, you know, the qualifying factors of what she looks for when she's going to meet with the family, or when she's looking at a chart.
So a lot of, you know, we've got our clinical data that I'm looking for, so how many times have they been hospitalized in the last 6 months to a year? What has dietary changes, weight loss changes, wasting in their arms of their muscle mass? Have they gone from a regular diet to a pureed diet or a mechanical soft diet? These are all early red flags that somebody might qualify for this free benefit. Skin issues, do they have a pressure to skin ulcer? What are they doing for ADLs? What did they do 6 months ago, a year ago, and what's going on with them now? 6 months ago, were they ambulatory with a walker, and now are they using a mechanical lift or a Hoyer lift? You know, what about their speech? Could they communicate and make their needs known 6 months ago, and now how are they with you? What about pain? You know, what if increase in pain? Have they made major changes to, like, and we're looking at major analgesics like the morphines, the, you know, Lortab, all those, you know. Constipation issues, what's going on there with them? What's going on with sleep and restlessness and anxiety? Have those things increased in the last 6 months? Recurrent infections, whether they're upper respiratory or urinary tract infections. So these are all red flags that can say, hey, maybe they might qualify for this free benefit, and you know, we can come and do a chart on it, whether it's here, a nursing home, your loved one, and see if they qualify for us. So that's all that, and then we look for disease-specific things. Okay, so with our heart patients, then have they had a history of an MI? Are they not responding to their diuretics? COPDers, are they, you know, not responding to their nebulizers, to their inhalers like they were 6 months ago? Or they keep your frequent flyers coming in, needing adjustments on those type of medications? So then we look at the disease-specific stuff. With Alzheimer's, we have to be, you know, very careful. They list A, B, C, D, you know, they have to be like a fast 7 where they're non-ambulatory, they're incontinent, they've had infections, so there's much more criteria for those, but usually if they have COPD or another comorbidity, we can get them on services. So.
When, let's just say that your discharge planner calls us, what's gonna happen then is if it's during business hours, somebody in our office is going to answer. When they answer, then we're gonna get the information, we're gonna go ahead and start talking to them about what's going on with the patient, and we're gonna ask if there's an order to eval. Once we find out what's in place from there, we will collect the data, and then typically a nurse is out just as quickly as possible, and she's doing the chart eval like she was talking about. We're in constant contact with the family at this point, and we're trying to have a sit-down face-to-face meeting with them as well. Once we have that meeting with the family and they say, oh my gosh, yes, this is what we want to do, then we're signing consents, and our nurse is then going through the assessment with the patient and getting this patient on board. That process typically is a 3 to 5 hour process. Every patient's different. But even if you guys have someone that is questionable, call us, because we definitely don't mind talking to the doctor, looking at the chart, and just taking a look to see. That's part of what we do as a partner with you guys. When we are here, Anna Maria can probably talk to you guys a little bit about like what it's going to look like when she's here. You know, when she's talking to you guys, what you guys might see us talking to the family about in and out of the room and stuff.
Anticipating their needs when they go home. Our last patient that was here and discharged to Carpenter, we knew that they were going to need an oxygen. We knew they were going to need a hospital bed. We knew they were going to need a bedside commode. So important with communicating, you know, with you all and the family on those needs and making sure those things are in place so that when they get there, it's a, you know, smoother transition for them.
So do you have a number that we call after hours then?
You do. That was the next thing I was
Okay,
going to talk
sorry.
about. No, you're fine. So, let's say that it's 6 o'clock on a Friday night. We're still going to come. You're going to call our office number, and the answering service is then going to pick up and either patch you through to the nurse or have the nurse call you right back. And the nurse is going to call back and kind of go through the same exact process as they would during business hours. We come all hours of the day, night, holidays, everything. We never close.
So we're available 24/7.
Literally. Literally, we're available 24/7. And the same thing to our patients once they're on service. We don't say, hey, we're going to see you Monday through Friday, 8 a.m. to 5 p.m. because guess what? People don't die Monday through Friday, 8 a.m. to 5 p.m. People don't have crisis 8 to 5 Monday through Friday. We're there when they need us. So we come when they call, we pick up the phone immediately and call them back and start, you know, just talking to them and finding out what's going on via telephone. And then we make the assessment as to, is this something that, you know, we can coach them through verbally, or do we need to physically go? The other thing too that is very important is we provide a death visit, no matter what. We have a lot of places facilities that will say, don't worry about coming. We're still gonna come. So if you guys call us and tell us, hey, we have XYZ patient that's on your service, they're here, they passed away, but we've got it, don't worry about coming. Well, we don't have a choice, we're still coming, because we want to.
Even if the patient's body's been released.
Right.
So we will still come because, you know, we're closing out our plan of cares. We're looking at the narcotics, what was destroyed, what was left, all those type of things as well. So.
And plus, we want to be here to provide support to you guys too. I know that in the smaller communities, because I live in one, we sometimes get close to our neighbors, we get close to our friends, family members, and just because we work here doesn't mean that we're immune to grieving. It doesn't mean that we're immune to being sad. So if there's something that we can be of assistance to you guys with, we definitely want to do that as well. You know, next, I think what I'd like to do is maybe just kind of open it up. Do you guys have questions for us?
What are the main drugs that you use on patients when they're in patient hospice? Do you use a lot of morphine drips or what's usually?
Usually it's just the morphine sulfate concentrate sublingual.
Okay.
And so, unless that's already been started prior to them coming on our services, but like at Mercy New Hampton, when we've had inpatient there, the liquid stuff works just fine.
So you won't have us put locks in the patients or anything?
No.
Okay.
No, we'll do oral sublingual, the same with the lorazepam, because that can be given. Sublingual, Haldol can come in liquid form, so we'll do everything oral sublingual for them.
Oh, okay.
First, because that's more comfortable for them. So.
Any other questions? Okay. We have to go through for your CEUs. We'll do it out loud and we'll go through it together. It's just a post-test, and we'll read the answers together too. I know that's really hard. I didn't think I'd make you guys take a test today. So, hospice recognized dying as the normal process of living. Do you guys think that's true or false?
True.
Good. Hospice Medicare benefit was initiated in 1982. That's true. Hospice focuses on the physical, psychosocial, and spiritual being of the individual.
True.
True. Those in hospice have more frequent hospital visits.
It's false.
It's less frequent.
And the reason is again because we're staying on top of those symptoms wherever they're at, managing them.
To be eligible for hospice, a physician needs to certify a terminal illness with less than six weeks to live. False. It's 6 months. And even if somebody, like if Anna Marie and I were both have the same disease, I might live for 3 years with it. Even if it's something that says that we're supposed to both pass away in 6 months, she might live a month. So, you know, there's processes that we take then to keep someone on service if they're eligible and their decline is significant. It just looks different for every person. But the doctor has to say yes, it is 6 months or less typically if it runs its normal course.
And then sometimes like the greater than 6 months patients are sometimes our COPDers, our heart people, our dementia, our Huntington's patients, because they're just getting that extra one-on-one, that extra TLC. We're managing those symptoms a lot quicker. And so as long as they're showing a decline during that time, it's okay. They still qualify for that Medicare benefit. And during that time period, our medical director needs to go do a face-to-face to make sure that they're qualifying for services. And so that's how they're on services for those long times, greater than 6 months. So
The hospice IDG team is comprised of the nurse and physician only. That's false. We talked about that earlier. It's the medical director and attending physician, the RN case manager, and LPN if needed, which we don't have LPNs. Hospice aide, social worker, spiritual care coordinator or chaplain, volunteers, therapists, and counselors in bereavement. Hospice can be provided in a nursing facility only. False. It's wherever the patient considers home. Eligibility for hospice is based only on frequent hospitalizations. False. Patients must have Medicare in order to qualify for the hospice benefit. False. The hospice provider will pay for medications, but not for medical supplies. That's false. We pay for any of the medications related to the diagnoses in which they were brought on service. And we pay for the medical equipment too. They need like a shower chair. We have some patients that need a Brita chair. Some patients need a hospital bed. Some people just need a special mattress. Whatever they need, we take care of. Once again, it's, you know, our utmost concern is making sure they're comfortable. The hospice provider has little communication with the patient's family members. Palliative care is the same as curative treatment.
False.
Hospice volunteers have little to no training. That's false. Our hospice volunteers have 20 hours of training right off the bat, and then we also put them through the infection and safety control and all of that we would our regular full-time employees. If there are any problems with a hospice resident, long-term care facilities are encouraged to call hospice first.
True.
True. A hospice nurse is only available during daytime hours, 24, or is it 24/7 by phone?
24/7.
Yep. Can you guys guess what our biggest complaint in hospice is? We are required, we send out surveys, and we are required to follow up on every complaint. I would say probably 90% of them, they come back as a complaint. They didn't have hospice sooner. But then we're required to keep, you know, a dialogue of it and what we did to follow up. But almost every single one of them says that's their biggest complaint is they didn't have hospice sooner. Yeah. So do you guys have any more questions for us?
I was gonna add one more thing to you all, is sometimes I hear as a nurse is that you're gonna take them on hospice and they're not a DNR yet.
Oh yeah.
That's okay. We meet the families where they're at. They're not ready to make that decision, you know, and that's okay, and that's why we'll have me and the social worker working with them.
Oh,
with
so
that
they don't have to,
transition.
so they don't have to be a DNR?
They can still
Really?
be a full code, absolutely. The same
Oh.
thing with medication. Sometimes they're not ready to get rid of the Aricept or the Namenda for the Alzheimer's. We're meeting them again where they're at. We recommend that they be discontinued at end stages because it shows that it's no longer effective. But if family's not ready, then that's where we're meeting them at. And when they're ready, then we'll discontinue those.
We try to talk to families in the manner of burden versus benefit. with everything that we do. I'm sure you guys have seen it. The hardest thing that a family member can do is say, all right, at this point, we're gonna not do any more feeding, because we see the family member aspirating on the food, and we know that it's no longer a benefit. But I don't know if you guys are like me, but the very thought of not feeding my mom or my grandma or whoever, it kills me. We eat for everything, you know, everything that happens in our family we eat. So we naturally want to comfort, you know, that loved one with food. So we approach it from the burden versus benefit. And a lot of times when we start breaking things down at end of life to that, they really start to understand, you know, hey, this is more of a burden for my loved one than it is a benefit. And they seem to understand it a little more clearly, I think. Well, I think that's pretty much all that I have for you guys. One more time, any more questions? No? Okay. Well, it's been great meeting you all. I can't wait to work with you. It's gonna be great.
Thanks for coming.
Yeah. You guys will just leave the candy in here. You guys can just kinda come in and out. It was all because it was her birthday, so you guys can say thank you to her.